right, thanks, Dr. Ayler. So good afternoon, everyone. My name is Jaela, and I'm one of our infectious diseases pharmacists over at the VA hospital. And so this presentation is actually a part two. It's a follow-up to the PKPD intro that Austin Morrison did last month. And so I know he did a great job doing an overview of pharmacokinetics and pharmacodynamics and kind of focused some time on renal dosing and critically ill patients. So today I actually wanted to shift the focus over to dosing in obesity. So, what I'd like to cover today is going over some background information to consider when approaching patients. We'll kind of go back over some PKPD principles, specifically those that relate to obese patients and how that can impact drug effectiveness. So I am going to highlight some dosing recommendations for just a few common agents that we use a lot and where there is data available. But of course, what we'll sort of find is that still very little data exists when it comes to making adjustments in antimicrobial agents for obese patients. As expected, it either comes from small population cohorts, usually retrospective data, various case reports. And often what we actually find is that a lot of the data that's out there is contradictory, or it might be too heterogeneous to even make good extrapolations from. So I also do want to share some resources with you at the end, so that way, at the very least, you will know where to go later on if you're trying to make a plan for a specific patient. So, what is the problem when it comes to treating infections in obese patients? So, first of all, we know that obese patients, they just have higher risks of infections when being compared to non-obese patients. So, this primarily is due to their increased number of comorbidities, vascular complications, slower wound healing, and an impaired immune response. So then when you add in altered pharmacokinetics, specifically increases in volume of distribution and altered renal clearance, and then on top of that, adding in the general lack of data available for how to adjust certain antibiotics, whether there is a risk of underdosing patients by using conventional doses available, or even a risk of overdosing if we simply approach these patients just by increasing the doses using total body weight. We also run into certain limitations because some antibiotics, especially in their oral formulation, only come in fixed doses. So when you add all of that together, it really sets up a situation for worse clinical outcomes. And we do have, I think, a good amount of literature to show that obesity has been associated with increased morbidity and mortality, specifically in patients with bacteremia, nosocomial infections, surgical site infections, skin infections. As stated above, it's been linked to impaired immune function. We know that these patients also have reduced immune responses to vaccines as well. So the circle on the left there is, really trying to find that balance of managing these patients with infections, finding the right, serum antimicrobial concentration, while obviously trying to minimize toxicity and side effects. And so interestingly, the Food and Drug Administration, the FDA, does not require pharmaceutical manufacturers to evaluate dosing recommendations in obesity prior to approval. It's not one of their, special populations that they require data in before review. And so the rhetorical question then, at the bottom of the slide is, is it possible, can we get to a universal approach for dosing modification in these patients? So A 70-kilo individual is no longer representative of a typical adult in the United States. The average American man now weighs right around 200 pounds or 90 kilos, and the average American woman now weighs around 170 pounds or 77 kilos. And so, sort of putting that together, trying to come up with the idea of what is an average American, it's right around 84 kilos with a body mass index or BMI of 29. And so when we use some of the definitions internationally, like the WHO definitions of BMI are the most commonly referenced, we can see that obesity is defined as a BMI of at least 30. And so half the US adult population will meet this definition by at least 2030, which we know is really not that far away. And then even severe obesity, meaning a BMI over 35, is projected to be a quarter of the US population by the same time frame. So obviously it's a very relevant topic to consider when it comes to approaching these patients when really we're talking about 50% of our patient population and a quarter of the patient population meeting that definition of severe obesity. So what are the issues then that we have with our current measurement or the definitions that we have? So obviously right now we rely on height and weight to both classify obesity and come up with our dosing adjustments. And, these are really referred to as, being pragmatic measurements. But as we know, these pragmatic measurements do not really paint the full picture. Adipose tissue, muscle mass, and organ function don't scale proportionally with body size. Sort of the classic example we can see there in that photo is three people who have essentially the same BMI, but we would not say that they have the same, muscle mass or lean body mass, or necessarily have the same, health status or comorbidities. So when it really comes to, what they call human body phenotypes, we know that they are quite diverse and can be very imprecisely captured by simply using height and weight. So specifically, when we start then talking about, antimicrobials, we know that we have lipophilic antimicrobials, which are going to be usually extensively distributed into tissues like adipose tissue, where when we think about body size descriptors, total body weight and thinking about volume and distribution would be more important for lipophilic antibiotics. Whereas in contrast, hydrophilic antibiotics, we would probably be more interested in knowing lean body weight or calculating an adjusted body weight. But to date, there really is no single size descriptor that's been shown to accurately correlate with either volume of distribution or clearance of antimicrobials in obese individuals. So, in different papers, you will see things, such as suggestions for using DEXA scan or skin fold measurement to also try to, come up with a size descriptor for a patient. When you read different papers on dosing antimicrobials and obesity, you will see, any variation of different body size descriptors, whether it's total body weight or actual body weight, ideal body weight, lean body weight, and then of course things like adjusted body weight and body surface area, which we know that body surface area is, certainly much more, whether it's well validated or just well used in the oncology field when it comes to, dosing chemotherapy agents. So, these different issues with current management and measurement is, some of the limitations that we have when approaching this task is because there is no single defined approach. And sort of a fun fact that I learned while reviewing this topic is the term ideal body weight is actually based on an actuarial data term that was developed by a life insurance company back in the 1940s. And so they came up with this idea of an ideal body weight to essentially describe what weight a person should be in order to have the lowest mortality. And so it was, not something that was derived out of the medical field or, pharmacy kinetics field. So I thought that was, sort of interesting that it's a term that we have sort of adapted in the medical world or in the pharmacy world. So this is an article that came up actually in the last PKPD talk, and I wanted to circle back to it today since obviously it's pretty relevant. So this was published in Open Forum back in April. And actually, if you do read through this paper, you will see at the end there is an acknowledgement to Austin Morrison over there at Moffitt Hospital. So I imagine this might have been a project he worked on either in maybe as a pharmacy student or as a pharmacy resident or in his last position. But anyways, a nice shout out to him. So here we have a retrospective multi-center cohort of a decent size, almost 600 patients, looking specifically at hospitalized patients with gram-negative infections. And they received definitive monotherapy with a beta-lactam for at least 72 hours. Patients were excluded if source control was unable to be achieved within those 72 hours, or if they had polymicrobial infection that were present that required, more than one antibiotic to be called definitive therapy. And so the goal was to classify patients based on BMI into non-obese and obese groups. So you can see there what the definitions were, so sort of following in line with that WHO classification. The median weight in the non-obese group was about 68 kilos, and in the obese group was 102 kilos. And so the most common types of infection in this cohort were UTI, respiratory tract infections, or bacteremia. And so their primary outcome was to define clinical treatment failure as a composite of either a patient that required a change in their definitive therapy because of clinical worsening, if they had residual leukocytosis 72 hours after treatment initiation, if they had presence of a fever after that 72-hour mark, or if they had a readmission within 30 days due to a reinfection with the same organism. And so, what they found was that the number of patients who met that definition of failure was roughly 33% in the non-obese versus 51% in the obese group. So obviously, more patients met the definition of failing in the obese group. And the most common cause of that was simply having unresolved leukocytosis at the 72-hour mark. Of interest, there was actually no difference found in mortality, but they did find a longer hospital length of stay. Of note, the obese patients were actually younger than the non-obese patients by almost a difference of 10 years. 67 years was the average age in the obese patients versus 74. The obese patients had poor renal function on the whole. They also had higher comorbidity scores, that were driven by, things we would expect, more hypertension, heart failure, chronic pulmonary diseases, diabetes, and chronic kidney disease. So, overall, this, is a retrospective cohort. It's really sort of just a reflection of what they found. They were not specifically concluding that the patients were necessarily underdosed or that the beta-lactam was, the sole reason for having the higher failure rates. Simply that, in this population with greater comorbidities, coupled with the potential for underdosing of antibiotics, we would anticipate experiencing these greater rates of treatment failure. The only other thing I'll say about this cohort is what did stand out to me, specifically because they were looking at beta lactams, was that they were primarily third generation and fourth generation, essentially cefepime, were the agents used in this study. And actually, there were only one patient in each group that was on piperacillin tazobactam, and also a very low percentage of carbapenems. And so I think we'll kind of come back to that idea of cephalosporin versus piperacillin tazobactam in a little bit. All right, so, that's some of the background, gearing up for this topic. So moving into the next part then, the PKPD, or the pharmacokinetics and pharmacodynamics. So really when I think about this section, I think about, three questions when it comes to agents is, do we need to increase the dose of the agent that we're using? And if so, what weight do we use? Total body weight or adjusted body weight? Or do we simply just need to give the antibiotic more frequently? Maybe we need to do both, increase the dose as well as give it more frequently. Or based on the drug characteristics, is no change needed for a particular agent? So that's sort of what we'll be thinking about going through the different PKPD parameters. So when it comes to pharmacokinetics, or the movement of drugs in the body, what is the body doing to the drug? We usually think about these phases of ADME, or absorption, distribution, metabolism, and elimination. So sort of going through each of these different phases, starting with absorption, there really is little data on changes in absorption in obesity. Obese patients have been shown to have delayed gastric emptying. This could possibly be as a result of just having a higher fat diet or gastric distension. Ultimately, we could have a lower Cmax or reduced absorption because of this. We also know that intramuscular injections certainly could be inadvertently administered as a deep subcutaneous injection. And ultimately, little is sort of known about whether that impact on absorption will also correlate with the impact in effectiveness. So then moving into distribution, when we think about distribution with medications, it's usually measured using volume of distribution, which is essentially a theoretical value, calculated by dividing the dose given by plasma concentration. So a high volume of distribution implies that a drug is distributed extensively into tissue, whereas a low volume of distribution implies that the drug is concentrated in the plasma. So most antibiotic classes will demonstrate an increased volume of distribution in obesity. And so although these changes they're not really easily quantifiable in relation to any particular parameters, especially when we think about lipophilic drugs. Other things that we also take into account with distribution, other than simply adipose tissue, is also just increased blood volume, increased cardiac output, and then also having poor peripheral perfusion. So we sort of have some competing factors as well when it comes to distribution. So with metabolism then, changes in hepatic metabolism associated with obesity are really largely unknown. So on one hand, we do have an increase in hepatic volume, but this is really more likely due to simply fatty infiltration rather than, an increase in metabolic capacity. So often we'll, also see these patients with the steatosis, hepatitis, fibrosis, CYP enzymes. Depending on the enzymes, I saw information that some CYP enzymes will actually increase in their, production and availability, and others will actually decrease. And then finally, when it comes to elimination, the effect of obesity on renal elimination is sort of also bidirectional. So on one hand, at baseline, obesity can result in a general increase in renal clearance. Again, simply by, just thinking about changes in organ size, changes in blood volume going through the kidney. But ultimately, it's not proportional to someone's increase in weight. And then on the flip side of that, you obviously can see a higher incidence of renal dysfunction. So certainly as the longer that someone, has obesity and develops comorbidities, if they develop hypertension over time or diabetes induced nephropathy, is where you sort of can see a decrease in renal clearance over time. So, sort of interesting, a lot of things to think about and consider as far as the impact of pharmacokinetics, but really difficult to sort of gauge whether that impact is up or down at different periods of time, and certainly over a diverse, range of population. So then, when thinking about how drug effectiveness is measured, so, we generally group antimicrobials into three PKPD classes, according to their relationship between drug exposure, pathogen susceptibility, like MIC, and then clinical response. So I think this is, a diagram that hopefully you're familiar with. And so we'll just kind of walk through this again. So first, thinking about concentration dependent antimicrobials, so peak to MIC, which is the ratio of the peak antimicrobial concentration to the MIC, Cmax. And this is what drives bacterial killing for these particular classes of antibiotics. So most commonly, we think about aminoglycosides, fluoroquinolones, sort of fitting into this category. And so when I think about antibiotics that are, peak to MIC correlating to their effectiveness, if I'm going to make adjustments to those agents, I'm going to care more about increasing the dose rather than changing the interval. So then the second group there, AUC to MIC, sometimes you hear it described as concentration dependent with time dependency. It's sort of like it truly sort of is a middle category between the two. So AUC to MIC, or area under the curve, sort of thinking about the overall drug exposure within a period of time. Here, you might be adjusting the dose, or you might be adjusting the interval, or you might be doing both for a particular antibiotic. And so obviously Vanco, certainly now that we have shifted sort of back to AUC monitoring for vancomycin, is really one of the easier ones to think about fitting into this category. Adaptomycin as well, I've seen classified as an AUC to MIC agent. And then so finally, time-dependent antibiotics. So the time that the free unbound concentration of the antimicrobial remains above the MIC is what drives bacterial killing. And so, of course, we are most familiar with our beta-lactams being a large class of antibiotics that are time-dependent. And so here, if I am trying to maintain the effectiveness or increase the effectiveness of these antibiotics, I certainly care more about adjusting the interval. So I'm going to think about dosing agents more frequently, or probably giving them as an extended or continuous infusion. Oops, one click too many. Okay. So let's talk specifically then about volume of distribution and clearance and sort of the intersection between drug dosing and obese patients. So as we said, volume of distribution is, physiologically determined by the volume of blood, the volume of body tissues and organs, and how the binding of drug in the tissues is relative, to that total blood volume. So in obese patients, the volume of distribution is going to depend on a few things, specifically the drug's affinity for adipose tissue and the amount of adipose tissue that there is. When it comes to an antibiotic then being able to distribute into the tissues, it's also going to be influenced by a couple different things that you can see there. So simply just thinking about what is the drug's molecular size, permeability across membranes, degree of ionization, and then you hear obviously us talk a lot about lipid solubility and protein binding. So we know that obesity is associated with an increase in adipose tissue and lean mass, and both of which can affect the volume of distribution of both hydrophilic and lipophilic antimicrobials. So it's sort of most intuitive to think about increases in adipose tissue, increasing the volume and distribution of lipophilic antimicrobials. But interestingly, we know that there's also increase in that lean mass. And lean mass can account for as much as 20 to 40% of an individual's excess body weight, in addition to thinking about that increase in blood volume that just comes along with that. So even because of that, you see that hydrophilic antibiotics can also have an increase in volume and distribution. When you really think down then into sort of the nitty gritty of volume of distribution, and you think about blood flow and cardiac output, while comparing adipose tissue to lean tissue, we actually see that blood flow into adipose tissue is really only estimated around 5% of cardiac output, while sort of the lean tissue still receives upwards of 70% of cardiac output. So actually, when you sort of couple that in these obese patients and potentially even having poor peripheral perfusion, sometimes antibiotics will actually have lower concentrations in the tissues because of those factors. So when it comes to different volume of distribution properties, here are some examples of hydrophilic versus lipophilic antimicrobials. And so really, again, to sort of, hit this point home, when we talk about volume of distribution with hydrophilic antibiotics, thinking about how to dose them and what weight to use, I am going to care more about using ideal body weight, lean body mass, maybe adjusted body weight when I'm dosing hydrophilic antibiotics that will have a overall lower volume of distribution. Whereas with lipophilic antibiotics that may have higher volume of distribution or more distribution into that adipose tissue, then we will certainly think about using total body weight and maybe adjusted body weight. So that's sort of the difference between these two classes. And ultimately, these are just sort of characteristics of these drugs you have to learn over time when you're, making choices for an individual patient. So then, other than thinking about, lipophilicity and volume of distribution, what else can impact dosing in obese patients? And so that brings us to clearance. So whereas when we think about volume of distribution, we're also probably thinking more about loading doses of antibiotics. When it comes to maintenance doses, that's where obviously clearance comes more into the picture, when to give the next dose and how frequently to give doses. So we already talked a little bit about having increases in renal clearance just being attributed to increased kidney mass, increased renal blood flow, affecting the elimination rate. Um, and so we also talked about comorbidities then influencing a decrease in clearance and how this issue can be bidirectional. So even if you sort of get past, those initial two conundrums, then we're sort of left with, well, how do we even calculate renal function in these patients? And of course, as with most of this presentation, there's not a clear answer on how to calculate clearance in obese patients. In general, we know that, using the Cockcroft-Gault equation is sort of one of the predominant equations used to calculate renal clearance. But it's also, carries some significant biases, especially when we use total body weight to estimate clearance in these obese patients. And so often it can overestimate their renal function. So there are some additional formulas that have been developed to hopefully try to improve accuracy, but obviously a lot of these are not, evaluated and proven in obese patients, really with the exception of the Salazar-Corcoran equation. And this was actually originally developed using obese rat models to develop the equation, and then they did have eventual patient data, to evaluate and validate the equation. So if that is an equation that you're familiar with or that your facility uses, certainly that is the one formula that has been studied specifically in this population. Otherwise, studies have looked at the MDRD equation using cystatin C, and a lot of papers, certainly like to conclude that at the end of the day, the most accurate way to gauge renal clearance is using a timed urine collection. But of course, we know that that is often the least feasible or sort of the least realistic way to calculate that on a, sort of everyday basis. So this is a summary diagram that comes out of a paper that I will actually show you the full reference for later. That is titled A Comprehensive Guide for Dosing Antimicrobials in Obesity. And so we just sort of see the overall summary here of PK parameters and how they can be changed in obesity, whether we have things that lead to increasing volume of distribution, and then the counterbalance on the other side, things that can lead to decreasing volume of distribution as well as decreasing clearance. And then tying that all together then, or bringing it in with the specific antimicrobial classes then, I thought this was a nice diagram where you sort of, had from left to right, that category of lipophilic versus hydrophilic, some examples of antimicrobials, their PKPD index of effectiveness, and then how those parameters change in both non-obese and obese patients. And so ultimately, what we see is that it kind of doesn't matter whether the antibiotic is lipophilic or hydrophilic. In obese patients, that volume of distribution is likely going to increase. And then that clearance being more bidirectional can either increase or decrease as well. And then I liked the suggested weight for dosing too, whether you should consider the, lean body weight versus maybe an adjusted body weight. All right, so then sort of the third part of this presentation then is going into a few dosing recommendations of different agents. I really didn't get into antifungals today. I did sort of stick to more antibacterial agents. And ultimately, this section can certainly get pretty dry of just, regurgitating dosing information. And ultimately, I think it is something that can be, looked up for a given agent, for a given patient, or certainly have your pharmacist look it up for you. So I touched on this idea earlier of, a weight-based agent versus a fixed dose agent. And so I just sort of wrote some examples of, agents that we're all familiar with being weight-based versus on the right side there, agents that are probably more fixed dose. And there's certainly many more agents that fall into that fixed dose category. And then I really thought that we do have some IV beta lactams that probably fall somewhere in the middle, where we do have more flexibility to adjust doses, as well as adjusting frequency and adjusting infusion times. So this was just sort of another reminder of the limitations that we are kind of up against when it comes to choosing agents. And perhaps if we do have an obese patient, maybe we would pick an agent that offers us options for weight-based dosing or flexibility, as opposed to the limitations of something that's more fixed. All right, so I was going to start off with aminoglycosides because these really do have some of the most data that exists out there. And so going through the drug characteristics, we know that aminoglycosides are hydrophilic medications. They tend to have a low volume of distribution, and their clearance is usually proportional to GFR. So when it comes to their PKPD parameter, we mentioned earlier that they are concentration-dependent antibiotics. And with changes in obesity, we would expect to see an increase in volume of distribution, with some of that distribution being to adipose tissue. So when it comes to choosing the weight for dosing, typically if I have a patient who is not obese, I'm going to stick to using that ideal body weight. But once they start to get over roughly 125% of their ideal body weight, the recommendation is to switch over to using adjusted body weight. So if you were to use total body weight in a patient, you will, especially in an obese patient, you will tend to overshoot those desired concentrations. So you'll get your high peaks, but you also likely get high troughs, which is what can lead to toxicity. Whereas if we do stick to ideal body weight on all patients, then we also run the risk of underdosing obese patients. So that's where we sort of get this correction factor of adjusted body weight of 0.4. And if you've never calculated an adjusted body weight before, I did put the equation down there for you, and I'm going to run through an example of what that would look like to use on a patient. So this is an example case. Just imagine having, a 75-year-old male, 72 inches tall, and weighs 190 kilos. And you would like to give this patient gentamicin, 5 mg per kilo. So this would be my approach to dosing. So with any patient, I do usually calculate an ideal body weight first. So taking the patient's height and using that equation, the ideal body weight is roughly 77 kilos. And then I need to know how far over the ideal this patient is. So by taking their total body weight over ideal, I can see that this patient is actually more than 200% over their ideal body weight. So, that already tells me if I'm going to be dosing an aminoglycoside that I'm going to use their adjusted body weight. So there's that equation there for you again. So by using that correction factor of 0.4, I'm able to calculate the adjusted body weight of roughly 122 kilos. So now I'm ready to dose my gentamicin at 5 mg per kilo, which comes out to 611, that I can simply round down, usually to 600 milligrams. So that's an example of calculating adjusted body weight for an aminoglycoside. So moving then into the probably most common, weight-based antibiotic that we use. So we have vancomycin, also hydrophilic antimicrobial with a low to medium volume of distribution. I think some of that is limited by the fact of how large this molecule is. And the clearance, again, is roughly proportional to GFR. So Vanco's volume of distribution does correlate well with actual body weight, but it does not increase proportionally with increasing body size. And actually, the volume of distribution has been reported to be lower in patients who have morbid obesity compared to patients who are not obese. So we actually see the volume of distribution go down in these patients. So when we're thinking about loading doses and loading doses being more dependent on volume of distribution, we might actually use lower loading doses in these patients who have morbid obesities. But ultimately, we're probably going to be limited by sort of simple dose capping at certain thresholds. So usually we see recommendations for loading doses of 20 to 25 milligrams per kilogram, certainly in critically ill or septic patients. And usually you will reach that cap using total body weight around 2,500 to 3,000 milligrams. For maintenance dose, then, again, we would certainly use clearance to help guide our maintenance dose. But here, I will usually also switch over to adjusted body weight. So I'm going to use total body weight for my loading dose, but for a maintenance dose, certainly for morbidly obese patients more than 140% over their ideal, I will switch over to adjusted body weight. And again, you're likely to probably hit dose capping limits or likely not want to exceed 4 to 4.5 grams per day. Usually in those patients, if you're even sort of entertaining those doses, you probably should be thinking about another antibiotic anyways, because you simply won't be able to hit those PK, PD parameters of the AUC to MIC goals. If you have an obese patient that does have normal renal function, you probably still need Q12, sometimes Q8 hour dosing in these patients just to maintain those AUC concentrations. So penicillin, so specifically piperacillin tazobactam. So there is, limited data on the effect of obesity on dosing requirements. What data we do have tends to come more from critically ill patients. We do know that obese patients tend to have lower unbound trough concentrations and increased drug clearance compared to patients who are not obese. And so here I've actually seen specific recommendations that, certainly using the higher doses of piperacillin tazobactam, that 4.5 gram dose, and then using an extended or continuous infusion that, either Monte Carlo simulations or data from specific cohorts have shown that those types of regimens do sort of meet that target attainment for this antibiotic. In critically ill patients, whether obese or non-obese, I recommend using loading doses of an intermittent infusion. So not giving your first dose as an extended infusion, but giving them sort of a bolus dose of 4.5 grams. And then for your maintenance dose, that's where you can use that extended infusion. So here at the VA, you might see an empiric regimen simply of 4.5 grams Q8 hours over a 3 to 4 hour infusion. And then there are recommendations for the morbidly obese with BMIs over 50 to even increase that frequency up to Q6 hours still as an extended infusion. So you see that recommendation certainly when there are, very severe infections, higher MICs, we will use that 4.5 grams Q6. And so some of that information is also extrapolated over to these higher BMI ranges. So a little bit on the contrary then with cephalosporins and specifically looking at cefepime is, still hydrophilic antibiotics, but we actually see this class tend to have higher protein binding. And so potentially we see increases of volume of distribution, but maybe not on the same scale as penicillin type antibiotics. So here there is limited data and less data, and I really only found specific recommendations for cefepime compared to other agents within this class. Again, the data that is available kind of comes from a mix of non-critically ill and critically ill patients. And I did not actually see specific recommendations for, increasing intervals or increasing infusion time. Actually, in patients with BMIs over 30, they found that traditional, even intermittent dosing was still appropriate, but certainly using the max dosing available of 2 grams Q8 hours. And then there was a recommendation, which simply comes from expert opinion, then in BMIs over 40 to consider using the extended infusion of 3 to 4 hours. So Adaptomycin, is another antimicrobial, hydrophilic, lower volume of distribution. Obviously, the data from the manufacturer labeling is weight-based data, and the manufacturer recommends using total body weight. And so I really found a mix of information out there in terms of, whether increasing dosing using total body weight actually increased, risk of side effects or not. And ultimately, the reference that I do tend to follow, which comes out of the LexiComp drug information system, is to use adjusted body weight in obese patients. And there was at least one paper that was able to find, as a retrospective review, that whether you use total body weight or adjusted body weight, that there was no difference in clinical failures of patients, and that ultimately they did find that there is a higher incidence of adverse reactions if you continue to use total body weight in patients. And so generally over a BMI of 30, then there is at least one recommendation to switch and use adjusted body weight. So I wanted to give an example of Lynaslid because this is certainly an agent that is one of those fixed dosed choices. So perhaps compared to Vanco and compared to Dapto, it does have a much larger volume of distribution and has lower protein binding. It sort of falls into that category of AUC to MIC. And concentration's not so much influenced by weight, but more so clearance. And so there's at least one reference that was able to find that standard dosing of 600 milligrams Q12 was able to provide, similar AUC values all the way up to a weight of 150 kilos. And then there's also recommendations that for patients who have even a BMI over 25, so not quite even meeting the WHO definition of obesity, but for a BMI over 25 with a GFR over 60 milliliters per minute, that you could consider a 600 milligram loading dose followed by 450 IV Q8 hours for potentially severe infection or higher MICs. There was also one reference to pushing the maintenance dose up to 600 milligrams Q8 hours, but it was, there was certainly a lot of caution with that recommendation that you only use that regimen if you have access to therapeutic drug monitoring or TDM, because there is sort of a very high risk for myelosuppression with that regimen. So I mentioned earlier that I wanted to share some references for you because at the end of the day, that's what you would be sort of accessing if you were coming up with a regimen for a specific patient. So these were 2 papers that I found most helpful, even sort of with the limitation of limited data. That top one there is the more recent article from at least 2017. 2017. And so within both of these papers, you'll certainly find pages and pages of tables for each different agent or grouping of agents and what sort of data exists out there and what would be potential suggestions for dosing modifications or where we yet still do not have any data. And so this is an example of a summary table from the pharmacotherapy paper on agents, and I appreciated that they also included a lot of the newer agents that are on the market that we probably have a lot of questions with as well. And whether it's, comforting or not, specifically for some of the newer agents at the top there, they said there do not appear to be dose adjustments or requirements for obese patients. We didn't talk specifically about carbapenems, but here the recommendation would be you could certainly consider extended infusions of carbapenems, like with piperacillin tazobactam. And then you can see in some of the other categories later down that there really are still agents where there's just inadequate or conflicting data in terms of what's out there. And for now, it might be reasonable just to make sure that you're at least dosing on the upper end of the range for severe deep infections. So then something that's maybe a little bit more accessible or sort of an everyday resource, of course, is Up to Date, has monographs on agents, and it's actually connected with Lexicomp, which I find to be a very well referenced drug information resource. And so you can see, if you're simply searching an Up to Date for a specific agent like Adaptomycin, it's very easy to see if there are specific dosing recommendations for obesity that you can get to. And so you can see, if you were to click this for Dapto, it would take you right to the section for dosing recommendations. And I do find that these are really well referenced, and you can, it's very easy to link to those references specifically if you want to know where that comes from. So then sort of, wrapping up today and how, what do I do with all this information? How do I ask myself these questions and approach patients? This is sort of what goes through my head as a pharmacist when it comes to coming up with an individual regimen for a patient. Obviously right off the bat, what's the weight? How far are they over the ideal body weight? Is the patient healthy obese or sick obese? Are they young? Do they have a lot of comorbidities? Do I have to take into account hypertension, diabetic nephropathy, poor vascular, blood flow? Do they have comorbidities influencing perfusion? What am I treating? Am I treating a bacteremia? Am I treating a diabetic foot osteo? Do I know the MIC of the organism? How does my antibiotic get to the site? Do I need a drug with low or high volume of distribution? What's the how is the clearance going to impact the effectiveness, and how did I calculate that clearance? Sort of after I have that patient information, the next questions I might ask myself are, do dosing recommendations even exist? So is there something in Lexicomp that I can refer to, or do I need to go and look for case reports or other published papers? What are the risks of either over or underdosing? Is the agent that I'm choosing have a narrow therapeutic index where there's a high risk for toxicity? Or do I have a beta lactam that maybe has a wider therapeutic window? And then, of course, can I do therapeutic drug monitoring on this? If not, how can I get it, right? I think that's the direction that we're probably moving to in the ID field, is more therapeutic drug monitoring. And the last question you should always ask yourself is, did I consult my pharmacist for help on dosing this? So once you've asked yourself all those questions, you're ready to walk through this, this nice algorithm here and get to a clinical cure for your patient. So no big deal, right? All right, so that is kind of brings me to the summary and conclusion for today. So really sort of a lot of lack of data for most antibiotics when it comes to dosing obese and morbidly obese. Having that background PKPD knowledge will certainly assist you with walking through some of those questions. We know that some antibiotics may require higher doses, where others may require more frequent doses. And sort of the future, I think, to look forward to is TDM, and then, maybe one day body phenotyping and getting away from pragmatic measurements. So thank you very much for your time today, and I'm happy to help answer any questions.